Well, again, thank you everyone. Welcome to today's Research in Progress webinar for the Robert Wood Johnson Foundation's Systems for Action Research Program. I am pleased to be your host for today's edition. This is Glenn Mays. I'm a professor here at the University of Kentucky, where the National Coordinating Center for the Systems for Action Research Program is based, and am again pleased to be with you here to hear another installment of research that's underway through Systems for Action Research Program. Just to give you a little bit of a preview of what we'll hear today, we're going to hear from some research underway by one of the collaborating research centers that's a part of the S4A program. And today we're going to hear from our research team based in Arizona at Arizona State University that will be talking about their signature research project that's underway, examining mechanisms for integrating financing and service delivery systems for populations with mental illness and substance abuse. And having spent a little bit of time with this research team over the last few months as this study has gotten underway, I can tell you you're in for a real treat. It's a fascinating approach and some really important I think opportunities for learning that will be coming out of this study as it moves forward. So we'll be hearing from several leaders that are a part of this study today. Dr. William Riley, who's well known to many of us who work in the health services research and public health services and systems research world. Bill is at the School for the Science of Healthcare Delivery there at ASU. Plays a number of roles there, both on the research and the system transformation front. He's joined with a few other colleagues at ASU who are co-leaders in this project, including Michael Shafer, who is a professor in the School of Criminology and Criminal Justice, and has a long record of scholarship in looking at issues of the interface between mental health and substance abuse and justice and criminal justice systems, as well as a third colleague we'll be hearing from today, George Runger, who is with the School of Computing Computing Informatics and Decision Systems Engineering at ASU. So obviously, and this is just a snapshot of the full array of a research team that has been pulled together at ASU for this project. So obviously a very multidisciplinary team that is coming together to study issues of systems integration for populations with mental illness and substance abuse. We're also very fortunate to have another great colleague in the health services research and public health world to serve as our commentary, our commentator for today, Dr. Stephen Teutsch, who is again also well known in the prevention research and public health research world. Steve is actually a member of the National Advisory Committee for the RWJF Systems for Action Research Program, and obviously has a long record of scholarship and service in the areas of prevention and public health. Most recently, he served as Chief Science Officer for Los Angeles County Department of Public Health, and also had a long and very successful career at CDC. Working on issues of prevention effectiveness research. So we're pleased to have Steve with us today to kind of reflect on some of the work that we'll hear from ASU today. And we will have some time for questions and discussion as we always do. Again, just a reminder, this is a research in progress webinar series, so we're going to be hear about work that's underway. And still at fairly early stages with regard to our research underway from our collaborating research centers. And so this is a great opportunity for our investigators to hear thoughts and suggestions and questions about research. And we'll make sure we've got time for that during the latter portions of today's webinar. Again, I'll take just a couple of minutes to remind folks about the Systems for Action Research Program for people who may be new to our program or new to the webinar series today. Again, this is a research program that the Foundation launched about a year ago now, really challenging us to expand our research lenses beyond the health sector to study ways of better aligning delivery and financing for medical care, for public health, and for the broader constellation of social and community services that relate to important determinants of health and well-being. And so through this research program, we are studying testing mechanisms for aligning services, service delivery systems, and financing systems across those sectors: medicine, public health, social services broadly defined. This research implicates many different sectors, certainly the health sector, certainly medical care and public health, absolutely. But these studies are extending beyond health into many other areas as well. As we'll hear about today, the ASU work is very definitely extending into criminal justice and mental health and substance abuse service delivery settings. Other studies are testing mechanisms that extend into income support, nutrition, education, housing, child and family services, and many other sectors as well. Again, driven by what we know about the services that drive and affect major determinants of health and well-being. We're also, through these studies, studying a variety of mechanisms for aligning those sectors and those delivery and financing systems and services. Whether we're studying organizational mechanisms like alliances and partnerships, financing and payment arrangements, which I know the ASU study intends to be looking at how financing systems are affecting alignment or lack of alignment across these sectors. Information exchange, and again, another important component of the ASU study I think we'll hear about today has to do with how we align information and data streams across sectors to learn where the bottlenecks are and where the opportunities for alignment are. So the constellation of studies that are being supported through the S4A are testing, again, a variety of mechanisms for better aligning delivery and financing systems across sectors. The current program structure, as you see here, there are 3 collaborating research centers which were selected earlier this year, began their work 6 or 7 months ago now. And again, ASU is one of those 3 collaborating research centers. The others are based at University of Chicago and at IUPUI in Indianapolis, and we'll be hearing from those other 2 collaborating research centers in upcoming editions of this webinar series today. We also have a number of individual research projects that have been funded through the program as well, being led by other investigators at other institutions around the U.S. 4 of these individual research projects have been funded to date, and we featured those studies in earlier editions of this webinar series. We'll be revisiting them as well as those studies move along and learn more through their activities. But you're welcome if you missed some of our earlier editions of this webinar series and want to go back and hear from some of the work happening from our other individual research projects. You can access those recordings on the S4A website. So without further ado, and these slides here just kind of summarize the major topics that are under study now through our collaborating research centers and our individual research projects. But I don't want to spend too much time on them because I want to get to our speakers for today so we can take a deeper dive into the work that's now underway at ASU. As I mentioned, we'll be hearing from 3 of the co-leads of the research project that's underway in Arizona, Bill Riley, Mike Shafer, and George Runger. And so without further ado, I'm going to turn it over to our ASU team, and I think Bill's going to lead us off.
Glenn, thank you very much. This is Bill Riley, and on behalf of my colleagues, Mike Shafer and George Runger at Arizona State University, I'd really like to thank you and the Systems for Action National Coordinating Research Center at the University of Kentucky, as well as the Robert Wood Johnson Foundation for funding this very important initiative. We really took the challenge seriously to develop new mechanisms to study multi-sector alignment to improve population health, well-being, and equity. And it's been a tremendous experience for us also. I'd like to have 2 acknowledgments, please, Ben. One is our research team, in addition to Mike and George, also consists of Mac McCullough, Brad Dublin, Kaylee Love, AJ, and Natasha Koltuk, and they've been very helpful in pursuing our multi-sector approach, as well as my gratitude to Dr. Steve Teutsch as our commentator. Steve is a eminently qualified person to critique and respond to our presentation and to help improve our approach as we go along. So thank you very much, Steve. So we are most interested in the problems of care fragmentation and conflicting financing systems, and we defined that as one of the major barriers to improving population health, well-being, and equity. And we selected the failure, the egregious failure of alignment within the multi-sector system for severe mental illness and substance abuse, and that's why we selected that topic for our study to develop these new approaches to alignment. And our goal is to achieve lasting change, and as already articulated by Glenn and the Systems for Action, that we really need different sectors to come together in innovative ways to solve these interconnected problems. So our research goal was to achieve better alignment among all the sectors that Glenn had mentioned in Maricopa County to improve care and efficiency for high-risk behavioral health populations. And Mike's going to talk more about the specific sectors that are involved in this research. We are using advanced data integration, data modeling, and visualization techniques to accelerate consensus on the policymaking decision processes among these separate sectors. And what they all acknowledge, and again, Mike will elaborate further on this, is that they're all working in their own silos. They're all working as hard as they can and the best they can. But the result is tremendous fragmentation and tremendous waste and very poor outcomes for this very vulnerable population. And one of the other real exciting ahas that we have had is as we've been developing this, and through Glenn's leadership and our other colleagues at Indiana and Chicago, is that our research actually is the intervention, and Mike's going to talk more about that. So we're really excited about that realization. So our four aims. First of all, we're going to create an integration quotient for every individual in Maricopa County. Maricopa County is the county in which Phoenix is located. It's about 5 to 6 million persons, and about 1 million of those persons are on Medicaid. So the integration quotient would express the total Medicaid spend for an individual relative to the spend on their physical health. And in order to really calculate that amount, we need to understand all the expenses among all the sectors involved with the severe mental illness. And that includes prison system, the court system, jail system, the community treatment system, and so forth, as well as healthcare and public health. Our second aim is to develop predictive models for psychiatric and general hospitalization. And George is going to show you that we are starting to identify the high-cost users. And again, for the professionals in the field between the different sectors, these individuals are not a surprise to them. They know them. But what we don't know is how do we achieve alignment between the different sectors in order to get better care, smarter spending for these people. And our third aim then is using a similar approach is to develop predictive models for the criminal justice systems. And again, we will be looking at the frequent users. We'll be looking at the pre- and post-book service patterns, and as well as concurrent service patterns for probation, behavioral health, and physical health. Our last aim, and this is the most important of all that Mike and George will both be talking about, is that our research actually is the intervention. And Mike will talk more about that, but we want to we embarked on this with a very robust and rich multi-sector partner, stakeholder, where we designed this for them to basically create the model specifications and to create the priorities in our multi-equation research models and so forth. But what we really are doing is using advanced visualization techniques that will put all of our policymakers together in the same room using a resource at Arizona State University called Decision Theater, where these persons, after they have spent 6 months to a year developing the models, establishing the priorities, and then we in turn are going to be, we've already started to acquire the databases to put together these very sophisticated models. And we believe our goal is it will substantially shorten the length of time to create policy, and as a result of this participatory research, they will create, the policymakers in the county, the city, the health department, the police department, and so forth, and Medicaid will all develop better policy quicker than would be without this intervention. So with that, I would like to transfer to my very dear colleague, Mike Shafer. Mike, can you take it from here, please? Mike, are you on mute?
Hello, Bill. This is George Runger. Mike has having trouble with the audio connection, so
okay.
They haven't been able to correct it yet. So you maybe need to continue.
Okay, I will do that. And then, Mike, as soon as you are available, please just let me know, and then you can take it from there. So our context is, as I mentioned already, serious mental illness as well as substance abuse. And then we are also including children in the SMI category. And as mentioned before, the challenge that we have is the very poor alignment and conflicting mechanisms for treating this very vulnerable high-risk population. And some of the early research that George and Mike have found, for example, is that in the highest use category of persons who cycle through the ED, the psychiatric wards, the community facilities, and the jail, they're jailed an average of 71 times a year. And so again, so the very frequent use of the emergency room and the homeless system and the criminal justice system and the first response systems, it's very, very fragmented. And let me just go to the next slide then. So we have identified and recruited and engaged stakeholders from all these sectors, and we have support and endorsement from the heads of all these organizations, the state and the county health policy and funding entities, psychiatric and mental health providers, the health plans, the relevant hospitals with their ED units, the psychiatric crisis response providers, both the police department and sheriff's department, the jail and the jail-based health service providers, the consumers and advocates for peer support services, as well as the mental health advocacy organizations, and public health is within all of our stakeholders also. So we really identified all of the stakeholders that we felt were relevant, and we also asked our stakeholders if there were others who need to be involved, and they also helped us identify and recruit others, because we do want this to be a holistic approach. And the assumptions that we made regarding the stakeholders is that they do have competing agendas and perspectives, and that's to be expected. And but the one thing they all want is better care for this population, and they're all committed to working with each other to help do that. So our goal is to create a greater consensus and collaboration for developing a culture of health for persons with significant behavioral health issues and likewise substance abuse. So we started from the very beginning. We recruited our stakeholder advisory group immediately, and convened them in June for a half-day session that we went through the entire goal of this program and received their input as well as their support and endorsement and willingness that they want to provide the information for how we are going to be developing our research models. And then likewise, we were doing pre and post tests with respect to their impressions and responses to our evaluation surveys in terms of what the actionable items are that we want to achieve and the extent to which they feel we are achieving it. This is one of the models that we developed for the participatory research. So looking at the top of the model with the three bolded areas. So we've got our current state that we'll be doing the analytics and modeling. We're working with the stakeholders to develop micro-simulation and stakeholder engagement and apply that evidence. And again, they're going to be developing the models. And then what we will be doing through the data visualization and Delphi techniques and other approaches is have them identify the future state in terms of what do they want this system to look like and how can they align the policy and financing. How can they find ways to streamline the disjointed medical services, the public health, social, and community services, and through our data visualization at the decision theater, to apply the evidence for them in online real time where they're all in the room together, and it's like a Walt Disney omni-theater where they can actually look at the results of their assumptions and then change the results right there to see what the impact would be as they develop consensus on what they feel would be a optimal policy. And ultimately, what we want is improved population health, well-being, and equity for this population. So here is a conceptual model of so we have our stakeholder advisory committee that consists of all those entities that were mentioned before, and they've joined three different work groups. The policy action work group where they're working on the policy both within their sector and then how to identify what policy levers they feel would be useful across sectors. In the upper right-hand corner is the data analysis and the data visualization work group, and they'll be helping to create the models that George is going to be discussing. And then down in the bottom is our dissemination and action work group. The total focus of this project, again, is not to do research. The total focus is to change policy and financing systems in order to improve health. And that's why it occurred to us that the intervention actually is our research project. So these are the different sectors, and this is could be a hard Venn diagram to show, but I'll just explain it conceptually. So in the upper left blue balloon is these are the databases that George and his team are using. So we have all the Medicaid data for Arizona, but again, specifically we're looking at Maricopa County. We're looking at all the balloon on the right side is all the hospital discharge data and data that is not necessarily in the Medicaid system. In the vertical big balloon on the bottom is the another database, and I'm sorry, I'm not even able to read it myself. It's so small. But that's the correction system. And then the
Bill,
county.
I could mention these if
yeah,
it's
please go ahead, George.
Okay, the bottom circles are the correctional justice system data sets. The adult probation data is in the far bottom, and the booking data is on the sort of in the pink in the middle. The small circle in the very middle is the correctional health organization. And these stakeholders we've all met with, and they've all agreed for providing this information. We currently have all of the state Medicaid data and the hospital discharge data set, which is the big blue on the right. And those data sets are fairly complete. And, you know, the Medicaid data includes information about enrollment, It includes dental and pharmacy claims as well as behavioral health claims. And we have the full state set of data. We're focusing down to Maricopa County on this starting project to get going. The correctional justice system data, we're sort of in the final stages to have that on board. We've already shared data tables and fields, and we have a good understanding of what kind of data they'll provide to us, but we haven't completed the step of pulling it in yet. The Medicaid and ADHS data is integrated, and then the next step will be to integrate the criminal justice system data.
George, thanks very much. Actually, can you take it from there, please?
Yeah, okay. The next slide has just some example summaries, and really the goal here is not to, provide conclusions because we're really not ready for that yet, but just to show sort of the direction or the type of analyses that we're heading towards. And these charts are really just one particular group. Bill had mentioned we want to look at several groups of patients, including kids. This particular group is just SMI patients over a one-year period in Maricopa County. It's April roughly 2014 to April 2015. The reason those dates were selected is there's been changes in Bill's earlier slide showed about carve-in and carve-out policies that went on in the state as to whether these populations were managed by the Arizona Department of Health Services as a carve-out or more directly by the state Medicaid agency as a carve-in. And there's also been some changes in the regional behavioral health organizations' contracts during those periods. And so this was a relatively stable period where we did have complete data, so it looked like a good starting point. The idea here is to quantify this data in the sense so those stakeholders can really look at data-driven decisions. And when they're reconvened for more or less the policy meetings that we refer to as visualizations, but it's really more than that. It's really system simulation that's part of those visualizations, where we allow them to quantify some what-if scenarios and other interventions like that. So the goal of this initial data is really to just provide some baselines for that following visualization interactions. And just as an example, the table there, I realize all this is hard to read. The intent, again, was just the type of analyses. For example, there was $127 million in costs for behavioral health over this one-year period, and roughly about $127 million was spent on physical health for these roughly 21,000 patients, for example. And the means and standard deviations refer to the per patient, or rather the per claims results. And the number of claims are shown there as well. The next slide is, and again, I apologize that they're small. What these slides show is each dot represents a patient, and if the chart on the left is red is the behavioral health costs, and blue are the physical health costs for patients. And you could see that there's a lot of variability. The little boxes on the left side are what are referred to as box plots, and those represent the 25th and 75th percentiles of cost for the population. So actually most of the population is in those little narrow boxes down there where they have fairly low costs. But you could see there's, as expected, there's a large number of outliers with extremely high costs. In fact, this data was a little trimmed because there's a few people that are well over $1 million that have been trimmed out so the chart can be displayed a little easily. But you can see, a fair number of patients over the 50,000 range for either behavioral or physical health costs. The charts on the right, again, it's early for us in this context, but what it does is it divides the patient into three groups based on their physical health. the three columns there are low, medium, and high physical health costs, and then the box plots in the middle are the mental health costs. And I think you could see a little bit that as physical health costs are increasing, simultaneously the mental health costs are increasing. I think we can display that a little bit better on maybe the next slide that's coming up. The final graph there on the bottom right is a ratio of behavioral over physical health costs. Again, some of this is hard to display in these rough cut brief presentations, but the vertical scale there is that ratio, and it's a log scale. So there's the range there is from very small values to the ratio up to very large values. And again, the box plot, you see sort of the 75th percentile. So most patients are, with a ratio of, you might say, 3 or so, roughly. That would not be unusual because this is an SMI population. There is a very large collection of outliers, though, as they move to 100 or even 1,000 times greater ratios of cost. This one is a very busy chart. I apologize, but it's the kind of things we're exploring with on how can we really get a handle on some of this. We really want to look at time trends. We do want to look at individual patients, for example. And if I just flip back, I should mention on the bottom right of this chart is a time trend. Each one of those vertical bars is the total cost for these patients over a 2-week period in that year. And you could see that it's fairly consistent over the year. There's 26 vertical bars here, 26 2-week periods in the year that are being displayed. So we are trying to look at things time-wise and patient-wise. When we come back here to our patients, each dot here represents a patient. So there's 21,000 dots on the chart. I know it's busy. That represent the behavioral and physical health costs for each patient. Again, it's a log scale on both the horizontal and the vertical axis on the chart, so we have to interpret it a little bit carefully there. We moved from $1,000 to $10,000 to $100,000 in costs very quickly. We do see there is a rough relationship, not very strong. There's a lot of variability in all directions, and that's really our task is to start digging in much further on this variability. But the blue line sort of shows a trend line. The data on the far right is too sparse to really have a good trend. But in the middle, we could see an increasing trend where the physical health costs are increasing along with the behavioral health costs. The chart is, these charts again are very small, but they're breaking out costs into different categories. And so for the far left, the behavioral and physical health costs per patient again, in terms of these box plots again, are broken out by race, ethnicity categories. And then on the far right, the same kind of diagram broken out by marital status on these categories. And these are just, the first look as we start to drill down and try and look at, combinations of marital status and race, ethnicity, and so forth, with a collection of demographic variables that we plan to investigate as part of the study to understand the baseline a little bit better. There is a little bit lower behavioral health costs maybe among the married population in our first cut of this data. But these are all things that need to be sort of explored much more depth. The last chart just shows that it's really, again, more of an example to show that we plan on partitioning the data in terms of chronic conditions. And so, for example, physical health and mental health costs are the two groups here. And they're further partitioned in terms of a number of chronic conditions for the patient. This chart is, it's hard to see, but the disease categories listed there are alcohol dependence, for example. Another category there is symptoms, signs, and ill-defined conditions. Another category is schizophrenic disorders. And so the point here is just to show that we do plan to look at the population by chronic condition breakouts as another category. So these were mental health categories, but we also plan to do physical health categories such as diabetes and asthma and so forth on the physical chronic disease side, and try and compare, how do diabetes patients, what do their behavioral health costs look like compared to non-diabetes patients and so forth like that, comparisons like that. And so our additional tasks are to start building in these physical and behavioral health comparisons between these groups. And remember, this is just the SMI group, and so we need to look at our alternative segments of the population. I just showed you one graph that talked about ratios, but we're planning much more analysis along those lines. We've already partitioned the population by deciles of utilization, so the top 10% of utilization, next 10%, and so forth like that. And we started to compare the top decile with the bottom decile. And we want to make those comparisons in much more detail, where we look at both behavioral, physical health costs in various categories between the top and bottom deciles of the population. We do have the full state Medicaid data, and so we are able, as needed, to compare to non-behavioral health populations is for additional controls. For example, with diabetes patients with or without behavioral health issues, for example. And then our next step is, I mentioned earlier, is the criminal justice data is not integrated at this point, but that's our big next step. The plans are in progress, and we're hoping fairly soon to integrate that data into the physical health data. We do have a good working relationship with most of the stakeholders. The center where we integrate the data has been working with local analysis projects similar to this for 15 years. So we do have a lot of experience on data integration, and we think that'll go smoothly once all the process steps are completed. And I think with that, that was the initial cut at the data analysis. Again, the goal here is to obtain baselines, is to look at the potential for natural experiments as the state underwent some policy changes over the time periods of our data, and to build this into system simulations models for when our stakeholders are convened, we could make data-driven decisions. As far as more details for next steps there, we do want to look at sentinel events, as Bill mentioned, as one of the earlier aims. I think it was aim number 2, where we're going to look at predictive models of psychiatric and general hospitalization. And as we pull the criminal justice data in, it will be sentinel events for criminal justice system encounters. So can we see patterns in the health or criminal justice data that would lead us to be able to predict some of those sentinel events? You know, the idea again is that may show gaps in the system, opportunities for system improvements if we could build some of those kind of models. And that, along with the visualizations, are next steps. I think with that, Bill, I'll turn it back to you for the timeline.
George, thank you.
More general. Yeah.
George, thanks very much, and I really want to acknowledge and thank our database and data analytic expert, Gavor Harutunian, who is just doing a tremendous job getting together all these databases. So 2 quick comments. One is, George mentioned, I want to repeat or reemphasize that this is just the Medicaid database. We're going to build into this also the prison, the probation, jail, and so forth in the court system. to get a full picture of the costs for this population. And with that, before I go on, Mike, is there any chance, are you piped in yet? Mike, are you on mute? Okay, so what I will do then is I wanted to acknowledge that Mike Shafer is our mental health expert, and he really has a lot to contribute to explaining this further. So this is our timeline on this slide, and you can probably the highlight of this slide is you can see how we have bundled together the data analytics and the policy from the very beginning all the way through until the very end. And it is our goal for this research to be the intervention for the policymakers to make more informed policy. And what we intend to deliver by the time this project is completed is, first of all, is that we will have a research design template for a multi-method, multi-sector systems for analysis. And to us, that's very exciting. All of us on this call have probably done a lot of research in healthcare and public health, but as the S4A paradigm indicates, we need to widen our lens to go out into the other sectors, and we're hoping that one deliverable, we intend that one deliverable will be a template for how to do that. And then secondly, more importantly, is by using this design template for multi-sector policy solutions to reduce the care fragmentation for vulnerable populations. So with that, Glenn and Steve, we'll stop there. Let me see. And Glenn, I'll turn it over to you and Steve, please.
Fantastic. Thank you so much, Bill, and everyone from the ASU team. So I think at this stage what we'd like to do is hear a little bit from our commentator for today about Steve's thoughts and questions and comments that may have been motivated during the talk, and then we will open it up for some larger discussion. So Steve, I will turn the floor over to you.
Great, thank you, Glenn. And first, kudos to all of you at ASU, Bill, Mike, George, and your colleagues for really taking on a very challenging area and looking at it in the kind of broad framework that you are. I think we all recognize that mental health is just not only an important problem, but it's been a very knotty problem for many, many years. And Bill, you outlined a lot of the reasons why that is. It's really very complex, and we seem to have a limited set of tools, so it tends to be an area that's both neglected and a bit frustrating. And in many ways underfunded, because it's not only is there not a lot of money going into it, but it's often hard to figure out exactly where that money needs to go to actually improve things. So just some aspects of that complexity. Obviously, it's a medical problem in terms of this management of individuals, but it's a healthcare system problem where we have the carve-out that you talked about, and the fact that it's not well integrated into the care system, and it's fragmented. The financing is a challenge, but as you relate, it's just so integrally related to many of the other sectors that are really traditionally outside the healthcare system, but which contribute not only to the problems of people with mental health, and make their job much more complex, but really exemplify some of the areas that need to be brought together. And some of them you've mentioned, certainly criminal justice, education. Some of the others, though, that come to mind are employment and ability to hold and function well in jobs and in families, and housing. So those seem to strike me as areas that one might want to incorporate. Certainly you're focusing a lot on the criminal justice system, but there are some others there as well. The Systems for Action folks, of course, build on the action framework from the Robert Wood Johnson Foundation. I just wanted to reflect for a minute or two about that, particularly for the people who may be less familiar with that action framework as part of the culture of health activities at the Robert Wood Johnson Foundation. And that action framework is intended to drive improved population health, well-being, and particularly health equity, and identifies 4 action areas. And it seems to me that while one can look at this work and say it addresses all of them, but it really is focusing on several of those action areas that I think are particularly relevant here. One of those is fostering the kind of cross-sector collaborations to improve well-being, and as we discussed, there's just a lot of these sectors that you're already pulling together, and others that are relevant. The third action area is creating healthier, more equitable communities. And the mental health arena, criminal justice arenas are obviously areas where there's not only stigmatization, but these folks suffer a great deal of problems that relate to equity, and in fact affect many of our minority communities in particular. So it's heartening to see that being addressed. But perhaps ultimately most important for this work, it's about how do you strengthen the integration of all of the services, whether they're in the healthcare system or outside of it, to actually improve this situation. So just wanted to share a few other thoughts as you proceed with this work and some of the reflections about how that might be relevant to some of the other Systems for Action work. I was particularly intrigued by the creation of an integration quotient, which at least I see as a way to develop a common metric that one can begin to use so that there is a clear measurement that all of the different stakeholders can work towards, and that really is a composite of many of the important factors that go into addressing this issue. And I think this is an area that we actually need to focus on much more broadly. So if you look at things like even environmental health, which there are areas where we could use a composite measure so that we're all on the same page in terms of what we want to achieve, and that are broad enough to incorporate all of the different stakeholders. So even though, now I'll use the environmental one as an example, so that as one has a composite measure, one can then begin to tease out the different components, whether it's air, water, safety in the community, building codes, and so forth. Much as we have that in economics with measures like gross domestic product, consumer price index, they're complex measures, but within that, everybody can look and see what their role is and what the opportunities are. I was particularly intrigued by the movement away from carve-outs, which have sort of siloed the mental health problems into a carve-in approach, which I think suggests a real change that we've begun to see, partly as a result of the Affordable Care Act, which is reflective of a change from the medical model to a where you can tease out the different components and think of them just in purely biomedical terms, to a much more integrated approach where you can see these problems in a broader context. I think there's also a real opportunity in that same context to think about how we organize systems around the individual rather than forcing the individual to deal with all the different fragmented pieces of the system. So the work that you're doing is clearly moving in that direction. You obviously have a very, very rich set of data sources, and it's great to see that you're in the process of integrating all of that, and some of that data is beginning to emerge. But linking that data is a big challenge, but I do think it's going to be exciting to see what emerges from that and the models that you're developing. as you bring all these folks together, they see the data, they have the visualizations, they integrate. I think it's going to be intriguing to see how they actually begin to move towards some common strategies and tactics, so that they actually can generate the kind of change that I know that all of you are seeking. And lastly, as I looked at this and thought about the complexity and the challenges, all of all of this, it struck me that there's always a question of how do you organize all of these stakeholders. So in this case, we're organizing things primarily around a set of mental health problems and all of its contributors. But one could organize it in other ways, of course, around criminal justice or health care or housing. And I think that one of the challenges is we can't organize everything around everything because we don't have the bandwidth to do that. So thinking about which are the sort of core issues that you can bring people together to focus their attention on is key. And I suspect that's different in different communities. So that one could organize this in some communities around major initiatives in criminal justice, whereas in others you can organize it more around the mental health or behavioral health issues or drugs or whatever the topic is that's likely to gain traction. So those are just a few thoughts. Again, kudos to all of you for tackling a really tough nut and trying to get to the core of the issues to make some differences. So with that, I'll stop. Turn it back to you, Glenn.
Fantastic. Thank you so much, Steve. I think you've given this group and our larger audience some excellent ideas for further thought and thinking about how to further develop the stream of research. We do have about 7 minutes left, and I do want to get to some of the questions and comments that we are being submitted from our audience on the webinar today. And again, if you could use the chat box feature, if you're with us on the online portion of today's call, you can type in your questions there. I'm going to try to go through the questions that we have already currently up there and see what thoughts this stimulates responses from our ASU team. So we got a couple questions about sharing the slides, and definitely the slides from today's webinar will be available on, be sent out to attendees and be available on the website after today's session. Let me see. I'm going to scan through here and see other questions. We've got a question asking about what are some of the cultural approaches that the ASU team has applied in their work with people who are not traditionally used to using the health technology exchange system. I guess the broader question about are there some cultural issues that need to be addressed as part of the study in terms of how your different stakeholders think about using or thinking about approaching integrating their data and using information from that work. Any thoughts from the team about cultural issues and exchanging and linking data and using that for decision making?
Great, Glenn. Thanks very much. And Mike, if your technology is squared away yet, again, please jump in. We'd be delighted to have your input in the Q&A session. And likewise, Steve, thanks so much for your comments and suggestions. They're very helpful, and especially I really like your point about the employment and housing sectors. You're absolutely right. That's very relevant. Regarding the cultural approaches, Mike, are you with us? Okay, so Mike still has the technology. George, do you want to comment on that, please?
Yeah, locally there is a sort of a concerted effort to improve the health information exchange, And so I think that the question is maybe addressing that sort of issue. Is once a more changes to promote the culture of health through the stakeholders and the intervention are in place, it's really an interesting question, because part of that will require greater coordination, which will rely probably on that type of technology that's going to be needed. And I think it's something we're going to have to look at, because different people are likely to have different comfort levels with using some of that technology. And so it's a question of how can the research project maybe identify those gaps at the least, and acknowledge that can be a concern. And then, in fact, the entire stakeholder group may have some suggestions for how to start managing some of those issues. Because that's absolutely right. That'll be important when interventions are to be implemented.
Fantastic, and we're getting a nice little discussion on the chat box now about some of the other kind of cultural elements here, and differences in culture between some of the sectors and stakeholders that you all are working with in Arizona, the culture of the criminal justice sector versus that of the health sector. But there's a question here about specifically, are there some strategies you're using about thinking about how to integrate culturally relevant services, especially for the Native American population that is more prevalent in your region? So any thoughts on that particular population and some of the cultural issues that may need to be addressed here?
Right. Go ahead.
No, go ahead, Bill.
I was about to say that Mike could definitely discuss that. Among our stakeholders, we certainly have those who are very adroit at the cultural relevance for all of our populations, or hopefully most of them in our service area. And that's where we will be able to receive their input. George, was there something else you wanted to mention?
No, that's fine, Bill. I was just going to say that was one of the subpopulations we did want to break out. The other part of that, I think that's somewhat important, is the earlier comments that we probably want to look more, as Stephen mentioned, focusing the stakeholders and focusing the kind of improvements and the stakeholders to some major initiatives. And so potentially we could select maybe just a few of those type of initiatives that might comprise a subpopulation or a condition, and focus more strongly on those.
Excellent point. I noted Michael Shafer is chiming in online, and also mentions, for example, looking at Medicaid reimbursement for traditional healers as part of the service delivery strategy there. So thanks, Mike, for weighing in online on the chat here. And maybe we got time for maybe one more quick question. I noticed there's a question about whether the jails in Maricopa County use the same risk to recidivate tool during the jail intake process. Is there a standardized tool being used across jails in Maricopa around looking at estimating their risk to commit crimes?
Well, the one thing I could say is, this is George again, is essentially everyone is routed to the same jail. And so it's not as fragmented maybe. There are some local jails, but the proportion of utilization of those is very small. And so but it's a good question, and I think it's something that we need to check, because it's certainly related to the questions of the booking data and so forth like that. So I don't have a direct answer, but I think at least we're not very fragmented there.
Yeah, and it looks like, George, Mike indicates on the chat mail that the answer is no, that those tools are county specific.
Mm-hmm.
But we'll certainly, go ahead.
Fantastic. Well, I know that, please go ahead.
No, good. No, that's fine.
Well, I was just going to say, looking at the hour, we're at our time. So I want to again thank our team from Arizona State University for a great Research in Progress webinar. Thank the excellent expert commentary from Steve Teutsch, and thank all of you for joining us today. Again, please stay tuned. These are all of these research projects that are part of the Foundation Systems for Action program. Are all in progress. We're going to revisit these studies over time in future iterations of this seminar series, and to continue to monitor progress and learn from these studies. Again, slides and recording of today's session will be available online shortly, and please join us for future iterations of this seminar series. November 16th is the next one. You'll hear from our colleagues at University of Chicago about the signature research project underway there, and then we'll be hearing later in December from our colleagues at IUPUI about their collaborating research study as well. Thanks so much for joining us. Please reach out to us if we can be helpful in the interim through our website, email, and other channels. Thanks so much, and enjoy the rest of your day. So long.